Welcome, everyone. We are absolutely thrilled to have you join the Medical Student Education Committee webinar. We're focusing on thriving in urology today, and we are so excited for this opportunity to spend an hour with you. So before we get started with the session, just a couple of great reminders. So the Medical Student Education Committee of the AUA is involved in a lot of exciting work for our medical students and learners. We have this year at Las Vegas, the Medical Student Forum in 2025. So it's going to be this year's new exciting lineup. We're going to have a panel of speakers, and then we're going to do the Medical Student Mingle, and that's going to be on Sunday, April 27th at 10 a.m. So if you're a medical student and you're at the AUA, I would sign up for it. We also have some very exciting other additional opportunities for our medical students. So we have our medical student curriculum. This is free to everyone, including our medical students. And we really do try to keep this updated. We have the current topics, the guidelines integrated in. We also have some teaching videos, and it's really a great resource. So you can check that out. I'd also like to highlight that when you're a medical student, you can join the AUA for free. And what else can you get at the AUA? You can get access to the core curriculum and a lot of wonderful perks courtesy of the American Urological Association. So make sure to sign up. Also, you can go on YouTube and see some of our previous webinars. We've had some great, exciting topics, including the forum, diversity in urology, as well as optimizing urology research. So please check it out. We have a lot of opportunities, and we really are excited to have you join us at the AUA. So let's get started to the task at hand, which is to talk about thriving in urology and giving you some strategies for sustained excellence and well-being. This is a very, I think, important topic, and our learners learning to do this sooner rather than later, I think, prepares everyone for even more success. So we are so lucky today to have 4 experts in the field join us. They're going to have different topics that they're going to cover. I just want to let everyone know that our topics are going to be about 10 minutes, and then we'll have a couple minutes for Q&A. So please use your comments and your questions. I'd love to answer in real time, but then we can also bring it back to the group if we have enough time. So we're going to invite all of our participants to join the room and give a chance to introduce them, and then we'll move on with the rest of the webinar. I want to thank everyone for being here, including our audience, our moderators, and importantly, I want to thank the AUA staff for setting this up. And in case you missed something, don't worry, this is going to be accessible on YouTube, and you can look back anytime, and you can maybe share it with others if you found it to be useful. So thank you, moderators and team members, for joining today. I want to first introduce Dr. Phil Parazio. He is a professor of surgery and chief of the section of urology at Penn Presbyterian Medical Center. He also has an exciting new role as vice chair of faculty development at UPenn, and he participates in many AUA and NCCN guideline panels and is an online content editor for the AUA. So his specialty is urologic oncology, but I think a lot of us see him as a specialist in life, and he's going to talk to us today about maintaining peak surgical performance. Next, we're going to have Dr. Susan McDonald, who is an associate professor of urology at Penn State Hershey Medical Center, also the urology residency program director, join us. She's also an editorial board member of BMC Urology and the Journal of Urology Open Plus. She does specialize in GU reconstructive surgery, but she's going to focus on discussing balancing childbearing and parenting in a demanding career tonight. Next, we will have Dr. Andrew Gabrielson. He is a chief urology resident here at Johns Hopkins University School of Medicine, one of my favorite residents, although I love all of my residents. And he's going to be pursuing a pediatric urology fellowship at Lurie Children's at Northwestern. And so he is a previous board member, and I think you were a founding member, is that correct, of the Society of Surgical Ergonomics? If not a founding member, you were very important and instrumental to the advancement of that society. And so he's going to be discussing optimizing ergonomics to prevent injury. And then we have Amanda North, who's a professor of pediatric urology and the chief of the Division of Pediatric Urology at Montefiore. She's also the chair of the AUA Data Committee. She has just been so inspiring to many of us in the field, and she's going to be covering fostering engagement while preventing burnout. So welcome to our speakers. We are so incredibly excited to have you join us today. And without further ado, I'm going to hand it over to Dr. Parazio to get started with the conversation.
Dr. Clifton, thank you for the wonderful introduction. It is so good to share the evening with so many good friends and like-minded individuals who are interested in long, healthy careers for surgeons and urologists. So, the first talk this evening is about sustaining elite performance. And it's a very specific title. So, first, I want to congratulate you all. You've made a very wise decision in becoming urologists and becoming surgeons. You have a wonderful career and a wonderful life ahead of you. But there are going to be some challenges. And so, the next 10 minutes, my hope is to give you some foundational thoughts as you progress through your career and your life. So surgeons are elite performers, and that's a very specific definition. Elite performance has to do with kind of the way you carry yourselves on a regular basis. It's the fact that we have both cognitive and physical skills in our work set. We're not professional athletes for a number of reasons. We're more in line with other careers like musicians or artists or the culinary arts, where once again, cognitive and physical skills meet on a daily basis. And once again, very different from professional athletes who have 3, 5, maybe 10-year careers. We're expected to have a 30-year career as a surgeon. And so there's lots of things we can do to keep or maintain that elite performance. And this is Maslow's hierarchy of needs. And this is a psychological kind of construct, but the basic premise is at the bottom of the pyramid are our basic physiologic needs: food, water, warmth, rest. And to climb up to the top, what he called self-actualization, these are those self-fulfilling activities. You have to make sure your pyramid is founded and has a strong base. So how do you do that? And how are you going to prepare through that through residency and through the next career? Well, these are kind of the three basic needs I see it for surgeons: sleep, nutrition, and physical health. And only when you can create a foundation of those three things can you move on to mental, emotional, and physical well-being. So sleep, I call it the great facilitator. The data says you should be giving yourself 7 to 9 hours of sleep opportunity per night. That doesn't mean your eyes need to be closed and you need to be asleep, but you're away from electronics, you're in bed, you're doing quiet things, and giving your body the opportunity to recover and making sure that you can be primed for the next day. You can catch up on short-term basis kind of over the weekend. You cannot catch up on monthly or yearly basis. And this is going to be tough as a resident, but you can try and build those opportunities in for yourself. In nutrition, it's all about caloric control and kind of understanding what you're putting into your body. And you're going to have goals. Is it going to be to maintain weight, lose weight, gain weight? And you can prime your day for the things you want to do. And men and women are slightly different here. In general, men want to prime their day with protein that puts you into a glycogenic state rather than a gluconeogenesis state and helps you kind of burn and maintain healthy weight. For women, you actually need a little bit of carbs in the beginning of your day to help promote the same process. Avoid a lot of liquid sugars. Alcohol has liquid sugar in it. I'm the first one who would never be able to get rid of, a cocktail here and there, but you can certainly limit those things. And we're learning more about veggie forward diets and fasting. And then importantly for our physical health as surgeons, you need to have strength and resistance training. You need to work not only on your core, but large muscle groups. They're going to be holding you up and keeping you active for the next 30 years. And you have to get comfortable working towards failure. And I'll touch on that in a minute. You need to be flexible. You need to preserve your muscles and your joints. You should be working cardio. And this is not only high intensity interval training, but also low zone training. So you could promote good cardiovascular health. And obviously body awareness is part of that too. Not only is this good for us, this is good for our patients. These are the American Heart Association and Cancer Society kind of guidelines. 150 minimum minutes of exercise per week. That sounds a lot, but it's really 20 minutes a day. And then you should be doing at least 2 times a week some really muscle strengthening activities as well. And it brings us to this concept of where we grow and learn. And you heard me mention we have to get comfortable working towards failure. And I'll give you just a simple analogy. Let's say you want to get bigger biceps. So you go to the gym and you do bicep curls. If you pick up a weight that's too light, you're not generating the stress on your body to generate bigger muscles or new neuromuscular connections. On the flip side, if you pick up too much weight or you work your muscles out too much, you can create stress, injury, problems, and you're preventing that growth. So when you're thinking about physical growth, emotional growth, when you're trying to build your skills as a surgeon, you don't want to always be in the fun zone. Yeah, it's nice and easy in there, but you're not necessarily promoting growth and learning. But you also want to try to avoid stressful areas and stressful triggers that are preventing you from learning and growing, ideally. And then that brings us to kind of something called cognitive dissonance. You want to figure out who you are and then make sure you align that with what you're doing on a regular basis in your career. It's tough during residency. You don't always get to choose what you're doing on a daily basis, but as you as you progress through your career and through your residency, you'll get more control and more understanding of what you want to do. And really importantly, you only have control of about 20% of what's going on in the medical world around you. So focus on the 20% you can control, not the 80% of the stuff that's going around in the medical record and insurance and all the things around you. If you're really interested in fixing those things, then you can climb the administrative ranks and help, but really spend your energy and focus on that 20%. And to help you figure out that 20%, you want to work on your purpose, who you are, and backing that up a step. To figure out who you are, what your purpose is, you really need to understand who you are as a person, deep dive into your values and your interests. And that relates not only to your clinical practice, but if you're interested in academics, what kind of work or research you're going to do, what kind of impact you're going to make in the field. And I will leave kind of in the last couple minutes with this. So a lot of what I teach and work on is founded in the basics of mindfulness. And it doesn't necessarily mean meditating on a daily basis, but being intentional about what you're doing, trying to spend as much time in the moment as you can. And there are three basic jewels of Buddhism in the traditional teaching. And the first is that deep internal awareness, the meditative practice. But the second is dharma or duty. And this is something we're all drawn to in medicine, where what we love meets real expertise and usefulness and compassion in the world. But the last and most important part of this is community. And we need to do this together. So not only do you want to build yourself, but you want to help build the people around you. And building the people around you will make you stronger and more resilient, and vice versa. So I'll summarize my quick points here in 10 minutes and under. So my keys for sustaining elite performance over a career: physical health is foundational to that elite performance. Think about that pyramid, really take care of the bottom. You will all of a sudden find you have more energy, you have more motivation, you have more ability to climb that pyramid and do the tasks that give you meaning. Embrace challenges. You are going to have to do hard things to grow. So be comfortable doing those challenging things, particularly in your residency. When you find something that is a challenge to you, is often a trigger or could become a trigger. This is an opportunity to learn. This is an opportunity for me to get better. You're going to have to continuously self-reflect. It allows you to align who you are and what you're doing, as well as your own concept of self and identity, and finally focusing on that purpose. And lastly, rely on and or create community resilience. Join the people around you. We have a wonderful community in urology. You're meeting 5 of us tonight who love each other and work really well together. So with that, I will take down the slides. I'd love to hear from all of you, and happy to answer any questions.
Well, thank you so much, Dr. Prazio. I do have a couple of questions that we've gotten through our team. So one question is, let's say you're starting out, you're a medical student, you're going to be a resident, hopefully a urology resident, because you just love all of us so much. But what if you haven't done exercise before? What if you haven't really done meal planning? I mean, a lot of times this is the first opportunity people have to move outside of an area of comfort and kind of be on their own. Do you have any suggestions?
I do. Two suggestions. First of all, be intentional about what you're doing. You hear all the time, oh, I started this diet last week and I hate it or I love it. Well, first of all, what's the purpose of the diet? What's the purpose of your exercise? It may be to lose weight. It may be to gain weight. I really got into yoga a few years ago, and the intention for that was I hated the way I felt at the end of the week in the operating room. I was trashed, and I felt a lot of it was related to flexibility or lack thereof. So I wanted to build in core strength and flexibility so I felt better in the operating room. Then once you have the intention and you understand, small steps. 90% of New Year's resolutions fail because people try to take on too much, right? Very small steps. This could be a 2-minute workout a day. It doesn't have to be that 20 minutes a day. Start with 5 minutes. Start with a 10-minute walk before you have dinner or after you have dinner. There's ways to kind of slowly build these things in. And once it becomes routine and you do it on a regular basis, you become to physically and then also psychologically expect it and look for those things. And when they're missing from your day, you'll feel it.
Well, I think that's really wise advice. Don't get too discouraged if you aren't successful immediately. And maybe that's just a sign we need to take some baby steps before we jump.
And give yourself grace. Listen, especially in residency, you're not going to have full control of your schedule. And if there's a day or a week when you're just in survival mode, that's okay too. We still have days and weeks when we're in survival mode as full faculty members. So it happens. It's part of being a doctor, but give yourself grace when you can't do it.
Well, and kind of along those lines, another question for you is how are we really supposed to find our vision? I think a lot of us have heard vision in general terms
Yeah.
as a student progressing throughout their training. How do we identify what vision is, or how do we kind of solidify that for ourselves, especially if we're just starting out?
Yeah, there's lots of ways to do this. I have my own personal beliefs on it. And I've also become a coach over the years. And this is one of my favorite things to work on with people. So the way I do it, and most people progress through some of this, is you want to start with first understanding what are your values and your value system. So what are the things that are important to you? Then putting those values in the context of your own life, right? We all have different life stories. We all have where we've come from, some major life events that define who we are, at least in our own mind. And then we all have a projection of where we want to be. So just with those three basic things, values, your kind of life history, and then your projection of where you want to be, that can help you kind of frame a purpose. And it'll start off broad and you'll experiment. You'll try one thing and you'll try another thing, and you'll find the direction that you move in is the one that makes you most happy and most fulfilled on a regular basis. And what I would say is it's okay to experiment and try those things. That's part of the process. And you're going to find failures along the way. You're not always going to love what you do. But what you don't want to do is just get caught in the hamster wheel and say, I'm a resident, I'm a faculty member, I'm just going to keep churning, churning, churning without clear direction. You're wasting so much energy and effort and potential happiness and fulfillment for yourself.
Well, thank you so much, Dr. Perazio. And also, he has his Peloton name up there. So if you want to race him in
Come
real
ride with me.
time,
Yeah.
that's right. I love it. I will not ride with you, Phil. You will destroy me, but in a very positive way to inspire, I'm sure. Okay. Well, thank you so much. And we're going to move on to our next speaker. And then if you think of any questions for Dr. Perazio, don't forget at the end, we're going to have an open forum for some more questions. So, Dr. McDonald, take it away.
All right. Hi, guys. I'm Susan McDonald, the program director at Penn State, and I'm here to talk to you about timing on when do you have children. It's a big question. Just for letting you know, I have two boys, ages 4 and 6, so I had them in my second and fourth year as attendings. I did a 6-year residency and 1-year fellowship before joining up at Penn State. I didn't get the memo on what happens to your body in pregnancy. I don't know why. I just wasn't that familiar. So I'm going to start with the basics in case anyone doesn't know. First trimester, you are really tired, just like arbitrarily tired all day. I would go to bed at like 7 p.m., just exhausted. You also feel really nauseous. Some people don't get it, but I lived off Zofran for my first trimester. Second trimester, you are more functional and you just kind of have a baby bump. Third trimester, then you are really large and in charge. And so you're waddling around. This picture on the side there, that's actually me at 37 weeks with my suspenders because you don't have hips anymore, so your scrubs won't stay up. You also stop sleeping, which is the world's cruelest joke, I think, because you have an infant on the way. And so you'd really like to get some sleep. But because your body is so unwieldy, you have lower back pain, etc., then most people get this pregnancy pillow featured on the bottom right, and it's tough to sleep. You also will feel tired because of the extra weight on your body. Postpartum, you're going to be getting up with your infant all night long. Postpartum depression is very real and very common. I probably had it both times. The first time with the first baby, it was very significant. Back to work, okay, fine. You do your time. I took 3 months each time, and then you go back to work and you think, okay, I've done the hard part, except not really, because the thing is, if you send your child to daycare, forgive my saying this, is a cesspool of germs. So you are going to get sick a lot the first couple years of your baby's life because like they get sick and then you get sick. So in thinking about when are you going to have a child? And I just broke it down to like before, like in residency and after residency, pros and cons. So in residency, you're younger. These are your peak fertility years. You have protected time. It won't affect your salary. It won't affect your promotion, etc. But con, if the lovely part of not having to front load or make up call is that it's going to go to your co-residents. So, you have to think about that. You also will probably take shorter parental leave in residency as compared to your time as an attending. You may take longer. ABU has certainly changed their leave policy. Kudos to them to be more accommodating. However, on average, people tend to take shorter leave. Also, you're not going to have as much disposable income, and that means you're not going to have as much money to throw at this problem of who takes care of your children. After residency, it's pretty easy to take the full leave if you'd like to. So I took 3 months each time, paid, as I said. You have more financial security and resources. So, if I need a babysitter, a nanny, etc., I have the money in the bank to pay for that. The problem is, as we know, women, particularly women surgeons, have higher risk of infertility as they get older, and higher risk of pregnancy complications as well. If you have your children in your early years as an attending, it may interfere with your academic productivity. I will tell you, it certainly did for me. And then, of course, there's the problem of being the old parent at the PTA. Also, you're just generally more fatigued. You have less energy. So I have 2 boys, 4 and 6, and it is WWE every night in my house after getting home from work at a long day. When you're thinking about what point in residency you might want to have a child, if you decide on residency, you want to think, do I have a lighter rotation, a research block? You might want to think about radiation exposure. Some people are fine doing PCNLs and they get the 360 lead. Some people prefer to avoid PCNLs. You want to think about the in-service exam, or certainly the board exam if you're post-residency. My first child was timed around oral boards. I will tell you that openly. Fellowship interviews, so you can't fly beyond 36 weeks. So if you are pregnant, you have to take that into account. How long are you going to take for leave? What's your support system? So I mean that in terms of both at work, who's going to pick up the slack, and also at home, who's going to help you with your increased home duties. And then what financial resources do you have? Like, do you have a spouse who works? Is your salary, are you the main breadwinner? How does that work? So I put this chart here of the 5 years of residency with the stars being where people tend to have children. I would recommend avoiding your first 2 years, mostly because intern years, like drinking from a fire hose, Urology 1 or PGY 2 is also quite difficult. If people tend to have a child in their early years, they do it at perhaps the end of PGY 2, early PGY 3. But then again, the problem is, you're going to have trouble when you're trying to learn big cases and you have small children keeping you up at night. A lot of people tend to favor having a child on their way out. So they're pregnant their chief year, and then they deliver sort of somewhere between halfway and the end of the year. The idea being, you do just recall that you have to take your written boards about, a few weeks after graduating. So if you have a child too close to graduation, then you're not going to be sleeping very well when you're trying to study for your written boards. So all of those things you want to take into account. Okay, so you've had your child. What is the aftermath of your child? So how do you get that child taken care of? You have some options. You can do daycare. They will take young infants as young as 6 weeks. However, if your child develops a fever to 101, they have to stay home for 24 hours. So you have to work it out between you and your spouse, who is going to take that hit, because it happens, and it happens pretty regularly. A nanny is nice because the nanny will probably show up in all types of weather, no matter what your child is doing, as long as they're not probably actively vomiting with stomach flu, your nanny will show up. The problem is it's really hard to find good help. So it will take you quite a bit of time to find a good nanny, and they're quite expensive. An au pair, by contrast, is a little bit less expensive, but the issue is that they have to have a space to live in your apartment, in your house, and so you need that kind of space for them. And also, au pairs are typically temporary arrangements. They're often people from other countries, so it's perhaps 1 to 2 years. Or if you are really lucky, maybe you have family who moves with you, or you're doing residency close to home, or multi-generational household where family lives with you. When you want to think about child rearing in residency, these are some things that some of which I knew, some of which I didn't. So I considered that I probably wouldn't sleep well. So now you're on call, you're working long hours, but in addition to that, your children have no regard for what you're doing the next day. So they will get up. Even now, my 4 and 6-year-old wake me up semi-regularly. So once you have children, they will wake you up quite a bit. It's 2 full-time jobs. So I didn't think about that. But the second you walk in the door from residency, which is very long, that child misses you and is going to want to see you and going to want to play with you. So you are on duty now as a parent. So, medicine and parenting are both full-time jobs. So as soon as you walk in the door, then you can't just go sit down on the couch and, have a beverage and watch a show. You have to play with your child, interact with your child. The other thing is, if you try to do any kind of Zooming or Teams meetings from home, forget about that. You will be Zoom bombed forever. I cannot tell you how many times my children join my Zoom meetings. And then multitasking. You will never again just do one thing at a time. You will always be, emptying the dishwasher while you're on a Zoom call, or, tucking your children into bed while you're, I don't know. You're also, I'm typically on Zoom calls. What can I say? And no presentation on parenting would be complete without adorable pictures. So this is my son, Cal. I walked in the door and he really liked my scrub hat, so he wanted to try it on. This is also Callan. I was writing a urology clinics paper as he napped on me. That speaks to the multitasking. And then, of course, one day I was on call, my pager's on my hip, and I'm answering my emails, and my older son, Finley's, just wanted to know what I was doing. So there goes the multitasking again. And that is my presentation.
Well, thank you so much, Dr. McDonald. I wish I had this information when I was going through this. I think you had yours after, I had mine during. Definitely a different experience. And I say that as my kids are yelling downstairs. So
it's so distracting when you're trying to Zoom. That's why I'm in my office, because I oftentimes use my husband's office, which he's in IT, so it's at home, but it's right next to my children's room. So I can't tell you how many times I've been trying to do a presentation and my children are screaming in the background.
So apologize to this group if you're hearing anything.
No, we can't hear it.
I blame my children. Well, as a program director, I have one question for you. As a program director, you've kind of seen the evolution of how we, helped our learners through parenthood and parenting. Can you give maybe your perspective on how we've helped make the learning environment maybe a little bit different than when you and I trained together, in terms of resources and maybe opportunities, I think, with this new focus on well-being for our learners?
Yeah, so at the time when you and I went through, it was openly discouraged to have children. And furthermore, people treated like having children, particularly for women, but also for men, was a distraction from your medical career, as opposed to something that brought joy to you and would bring balance to your life and longevity to your career. Because let's face it, if you only do one thing with singular focus, then if you can't do that thing, what have you got left, right? You want to diversify. You want to have hobbies and interests. You want to have children, a family. I think you should be, it's my own personal core value, a Renaissance person. A little bit of everything is good for life. So I think now we've acknowledged work-life balance and that it is actually good for people to have a happy home life. And that brings them joy, and it makes you less likely to burn out in your job. So now I think firstly, we talk about it openly. So there are women like you and I who now talk openly about our experience with childbearing, and that gives mentorship to our upcoming trainees, right? Like they can have those conversations and debate. They could talk to you about having a child in fellowship or residency. They could talk to me about having a child as an attending, and we could, debate what the pros and cons of that are. I think the other thing that's really shifted, like I alluded to, is the ABU has changed their policy so that women are able to take longer leave periods. I also think what's good for the goose is good for the gander. Men now have parental leave too. And I remember as a resident, some of my co-residents, their wives had babies. They were operating. In between cases, they went and said hello to their infant and went back to operating. Now, my residents, my male residents whose spouses have children, they take 2 weeks off, which is nice. I think it's important. I think if I had, if my husband didn't have parental leave and I gave birth to a child and he was just absentee, I'd be pretty upset about that. So I think it's good for all parties, male, female, whatever gender you want to call, to engage in a family life and to have the time and space to do that. And I'm glad these conversations are happening.
Well, thank you so much for your perspective and for being so honest, and I think helpful to all of our learners on the call. Make sure that you enter your questions because we will have a Q&A at the end. And we're going to move on to our next topic with Dr. Gabrielson and ergonomics. I think Dr. Gabrielson actually had a great paternity leave and enjoyed his time. So again, he can talk about that, but let's focus on surgical ergonomics.
Awesome. Thank you, guys. Good evening. My name is Andrew Gabrielson, and I swear I didn't plan this with Dr. McDonald's talk, but I'm currently experiencing the joys of getting sick, courtesy of my 7-month-old who's at daycare. But also to echo, I wouldn't trade it for anything in the world, so balance is possible. So tonight I get the pleasure of discussing surgical ergonomics. I think that this is a topic that really every urologist and urology trainee should become facile with. And ultimately, I think the goal is really for career longevity. So why is ergonomics a topic that is relevant to budding urologists such as yourself? I think simply put, work-related injury is common, it's costly, and it can be career limiting. Surgeons experience work-related pain and injury at rates that rival that of high-hazard industries, such as construction work and maintenance. And estimates suggest that about 1 in 5 surgeons will require days away from work, either from a work-related injury or kind of another kind of adjacent issue related to kind of their wellness. And this can have substantial impacts on workforce shortages. Additionally, replacing a physician is hugely costly to the healthcare system. It's been estimated that it costs about $250,000 to replace a non-surgical physician, and the estimates go up to upwards of $1 million to replace a surgeon. And so this is kind of a major issue.
Dr.
I think the other.
Gabrielson, we do not see your slides advancing. I think it's technical difficulties.
Let me see if I can redo it again. No problem.
It's amazing.
How about now?
Let's see if we can see him. Yes, thank you. Appreciate it.
So work-related pain is common among urologists and trainees, and studies have shown that pain rates between faculty and trainees is actually somewhat similar. And so it suggests that some of the sequelae that go on with being a surgeon and the related pain kind of effects are actually agnostic to your level of training. So this is really something that's important, not just for urologists that are experienced and kind of seasoned in their career, but also trainees as well. Unlike other surgical specialties, we are trained in virtually every surgical approach, from the least invasive in-office procedures to the maximally invasive open and robotic-assisted surgeries. And so the urologist's practice is unique in that we must cope with this very wide array of very distinct ergonomic environments. And so each of them also has their own set of challenges, which we have to. Unfortunately, very few urologists actually receive ergonomics training. And this is something that most urologists are actually very eager to receive such training. So this is something that has already kind of penetrated the scene in general surgery. They're starting to incorporate it into their curricula, but urologists are just starting to catch on. So, I could spend the entire, this whole hour talking about every kind of ergonomic recommendation based on each surgical approach. But what I'd like to do is give you guys a quick crash course and just focus on some of the highest yield topics for body positioning and OR setup. And I'm going to discuss conventional laparoscopy. I'll talk about endoscopic surgery, and then I'll focus on robotic assisted surgery and open surgery. So in conventional laparoscopy, we are kind of facing the patient at a certain angle where our arms are able to kind of triangulate with the target anatomy. And so there are things that you can do really at the start of a case to optimize your posture and also optimize the axis in which you are operating. So, kind of one of the most important things to do is to optimize the position of the monitor that you're looking at. That's where you're going to be facing for the entire procedure. And so in general, you're going to want that monitor to be directly in front of you, basically perpendicular to the operating direction. You're going to want it to be about 3 to 4 feet away from where you are operating. And you want the monitor to be either at or just below the horizontal. And the reason for that is that our eyes naturally prefer to have gaze down vision. Like we prefer to be looking down ever so slightly, and that's the reason that we look at computers the way that we do. And so that's something that you can easily adjust at the start of a case, and that can pay dividends for a 2 or 3 hour case that you're doing. Another thing that's worth mentioning is port placement. We get very fixated on kind of doing the procedure, and we just want to make sure that we're able to get the work done. But if we're very thoughtful on how we place our ports, in general, you want to be creating large, broad-based isosceles triangles with your target anatomy. You're going to be able to avoid very extreme horizontal and very extreme vertical orientations for your arms. And ultimately, your elbows can stay kind of tucked up against your trunk, and that also minimizes the need to pronate and supinate your wrists. For robotic-assisted surgery, the key to good ergonomics is focusing on the seated position. This is something that you can do thoughtfully once and save these settings in the console, and then you never really have to think about it again. The ideal body positioning at the robotics console, as you can see in this figure, you should be sitting flat on the chair. Your thighs should be parallel to the floor, and your thigh and torso should create roughly a 90-degree angle. Seems simple enough. You're going to be sitting up straight. Your knees should be slightly extended, and your feet should be able to rest flat on the ground only a few inches from the foot pedals that you're going to be engaging throughout the case. The armrest should be set such that your arms can form roughly a 90 to 120 degree angle. And then you should set your stereo viewer, which is what you're going to be gazing through the whole case, so that you have the gaze down vision. So ideally, and some of the models of the robot do not allow this, but some of the newer ones allow you to have that vision so that it is almost on the horizontal or just below. And then lastly, if you can find a chair that has lockable wheels, that's really ideal because it allows you to kind of push your butt back towards the back of the chair, and that ultimately gives you lumbar support throughout the case. And although a lot of this sounds very, very technical, this is something that you can do thoughtfully once, save all your settings in the robotic console, and then you can recall them at the start of the case and never have to think about this again. One of my colleagues through the Society of Surgical Ergonomics actually wrote a really nice paper on this. And a lot of the steps that are listed here are similar to what I just described, but it basically provides a stepwise approach to optimizing your ergonomics of the chair. And ultimately, your workflow when you come into the OR is very simple. You set the chair height so that your feet are resting flat on the ground, and then recall all your settings, and you don't have to think about anything else. One thing I will also add is that one of the most common mistakes in terms of body positioning while doing robotic assisted surgery occurs when the shoulders are abducted away from the body. And this typically happens when you're working kind of at the periphery of the working envelope of the robot. You're trying to work on some sort of tissue that's far away. And so the tendency is to lift your arms up and reach for that tissue. But what you'll notice if you watch some of your more experienced robotic assisted surgeons is that they are using the clutch control system, which are these little tethers on the manipulators, which allow you to move the arms without the robot to a more ergonomically favorable position. And you'll see experienced robotic surgeons are doing this all the time. So always be clutching. For endoscopic surgery, a lot of the same recommendations that I mentioned for conventional laparoscopy are also applicable to endoscopic surgery. And that's namely for things like the location of the monitors. But there is some caveats. I think the most important one is table height. Human factors experts typically recommend that you should set the table height such that your working area, which in an endoscopic case will be the urethra or an access sheath, is roughly between the surgeon's pubic symphysis and the belly button. And that's when you're operating while standing. And ultimately, what that does is it minimizes the amount of abduction that you have to do with your hands to be able to manipulate the instruments. Another thing that I will mention that we frequently wear lead aprons for endoscopic surgery. And usually we're in a rush and we kind of run out into the hallway and try and grab whatever lead we can. But if you see two pieces of lead, one that's a two-piece set and one that's a one-piece set, in general, it's ergonomically favorable to use the two-piece lead. And the reason being is that the two-piece set allows for greater accommodation of the lead apron's weight on your pelvic brim. And so, you can use one-piece lead. There's nothing wrong with that. But if you're going to be doing that, make sure that you use the waist belt. And typically those waist belts are lost or missing, which is why I usually recommend the two-piece lead if possible. And so I just went through a ton of recommendations. And, a natural, curious question could be, is there any evidence to support a lot of the things that I just mentioned? And there is not level 1 evidence for a lot of the things that I've mentioned so far, but a lot of these recommendations are supported by evidence in other surgical specialties. And most of these specialties are performing analogous procedures, and there is good data to support this. Additionally, this was a study that we did a couple years ago where we asked a bunch of urologists who perform flexible ureteroscopy, are you adhering to some of these ergonomic best practices? And then tried to correlate that with their pain. And what we found was that a lot of urologists were not, adhering to most of these recommendations, but the few that were routinely implementing all these recommendations had less pain in nearly every muscle group. So there is some value to doing this, even in the short term. This was kind of short-term pain assessments. And then lastly, for open surgery, there are a lot of recommendations about how to position your body to reduce injury with open surgery. There's so much variability with open surgery, it's hard to standardize it. But if we're talking about transabdominal surgery, I think the most important takeaway is to be very cognizant of your neck posture. Especially as trainees, we have the tendency to be leaning over the incision and trying to kind of get a better look at things. It's something that is just a natural tendency of trainees. I am certainly to blame as well. And one of the issues is that for every inch forward our neck is craned, it adds about 10 pounds to our cervical spine in terms of kind of torque. And so this weight is also compounded by anything we're wearing on our head. So think about things like loops and headlights. And so very quickly you can develop cervical spine issues if you're not cognizant of kind of sitting up straight. And kind of the main way to address this is the table height. So if you're working at the level of the patient's skin, in general, you're going to want to set the table height such that your elbows can be at roughly a 90-degree angle and your hands can rest flat on the patient's surface. If you're working deep within a pelvis, you're going to have to raise the bed a bit higher. And that's because your target anatomy now is not at the surface level of the patient. It's down deep within the pelvis. And so you're going to want to probably raise the table a few inches, above what you would be typically used to if you're doing, kind of deep pelvis work. And then one other thing I will mention, it is listed in this figure, is that anti-fatigue mats, they are widely available in most ORs. A lot of people do not use them. They're actually one of the few ergonomic interventions that are out there that have been supported by randomized controlled trial data. And they've been shown to reduce leg and back discomfort. So this is something that if you see it, try it, it's worth it. And then the last thing I'll talk about is loops. Frequently, we are going to be purchasing loops when we're, a fairly, if you're going to be choosing a loop set, my only recommendation is to buy the lightest pair possible. This is something that you are going to wear frequently. It's something that easily contributes to neck and kind of shoulder discomfort. And in general, the heavy loop frames are not necessarily translating to any better vision or any better security on your head. And so that's something that is easy to implement when you're looking at your loops. Last thing, these are some resources. The American College of Surgeons has a free booklet of surgical ergonomic interventions, and they have really nice figures that you can follow. There's a Nature Review paper that I worked actually with Dr. Parazio on, which is a primer for ergonomics for the urologists, but it's totally relevant to trainees as well. And then there's some update series that have also featured topics related to ergonomics and endourology. And thank you for your attention. And here's my contact information if you want to connect.
Dr. Gabrielson, great talk. And most importantly, for everyone listening, this is really vital information. So it may have seemed like a lot, but I would encourage you to look at those various resources. If you set yourself up for success now, you're going to be even better off later. Andrew, I know you're sick, so we really appreciate you joining us today. That's just the way it works in the flu season. But I did have a question. I had a question, for our learners that are coming in, and there may be this power differential. They may have an attending who's very loud. Maybe they just are worried about speaking up. How do they advocate for themselves to make sure that they have an optimized OR experience?
Yeah, so that's a great question. I think that we have a tendency as trainees to want to be deferential to our attendings. We don't want to rock the boat, so to speak. I would say the easiest thing to do, and this requires kind of no confrontation whatsoever, is get to the room early. And you can actually optimize some of the setup for yourself before anyone's even in the room, including the patient. So that's something that I think is very easy, especially with things like monitors. Some monitors are trolley mounted, some are mounted to the ceiling. Most of the time, these are things that people aren't thinking about. So you can actually optimize most of your setup before the case even starts. The other thing that I think is definitely worth mentioning is that most attendings, I've just been very lucky, are very receptive to bringing up these issues, being like, is it okay if I bring the table up a little bit? Like I'm craning my neck. Most people are like, oh my gosh, I was thinking about the next step of the procedure. Yeah, of course. Yeah. Raise the table. And then I think one other thing that I think is worth mentioning is that there is some work that's being done to try and create some sort of checklist that would run in parallel with the timeout that would actually incorporate ergonomic kind of components into the timeout. I think that this is, something that we do to protect patients and make sure we're doing the correct sided surgery and we're doing the right procedure. And this is all focused on patient safety. But, I think it's also a perfect opportunity to mention, factors related to surgeon and surgical team safety. And I think by creating sort of a timeout that is separate from the trainee, it also kind of normalizes discussions about this. So that's actually something that's in the works and is currently being worked on right now.
That is some great advice. Set up early and then also do it in the timeout. When you're the surgeon, you do have control of that timeout, so you can talk about the things that are important. And we'll save the last few questions for the end. We are moving on, and Dr. Amanda North is going to join us to talk about engagement.
Well, hello. I know it's getting late in the evening, and I don't know about you all, but I go to bed early because, like Dr. Frostro told us, we need to get a good night's sleep. So I'm going to talk about engagement, and this is not the kind of engagement that leads to marriage and then babies, like Dr. McDonald talked about before, but this is the kind of engagement that means that you are really focused and involved in what you do every day. So a lot of people think that the opposite of burnout is wellness. And Phil talked about wellness, and I love everything he said. We should take good care of ourselves. We should exercise, watch how much alcohol we put in our bodies, watch our telephone addictions, which I think is one of the worst addictions we have in this day and age, get good night's sleep, and take good care of ourselves. But you can be the fittest, most wellness-focused person in the world. And if you work in a terrible environment, you're still going to be burned out, right? If your clinic is inefficient, your OR turnover is terrible, they never have the equipment you need, no matter how much you engage in mindfulness meditation and how fit your body is, you are still going to be frustrated by your job. So I would argue that the opposite of burnout is actually engagement. It's being engaged and dedicated and absorbed in what we do every day. It's finding that meaning in work. And this, of course, depends on all sorts of things, right? It can depend on the regulatory laws that impact our everyday lives. It can depend on how well we get along with our nursing staff. It can depend on how good a night's sleep we had or whether or not our children are sick. But the more we can focus on being engaged in the work we do and in our personal lives, the happier and less burned out we're going to be. Why is this such a big issue now? So this is AUA census data showing the percent of employed urologists, and these numbers have continued to increase. 2/3 of us work for somebody else. Now, back in the day when I was a child, my pediatrician had an office attached to his house. He lived across the street from us. And if I had an ear infection, I got a lot of those as a kid, we would just walk across the street and he would open his office and see us. He worked for himself. That is not the model most of us are going to experience in urology practice. And with that loss of autonomy comes some issues, a loss over control over some of our work environment. So when we think about drive or we think about engagement, it's really that intersection between purpose, which Phil talked about, mastery, which is part of what ergonomics is about, and how much autonomy or say we have in our work environment. And that is really where the key is to being engaged in our work. So how do we increase autonomy? So of course, in the OR, when you're a resident, increased autonomy is your reward for increased mastery, right? And increased autonomy in decision-making on the floors is also a reward for increased mastery. But what about those of us who work in an employed model, which again is at least 2/3 of practicing urologists? And some days it's easy to feel like if you work for somebody else, you work for the man, I don't mean to be sexist, autonomy is lacking. And so some things to think about as you're entering residency and then practice after that is to look for jobs that give you some measure of autonomy. One ways I manage my schedule is I'm a pediatric urologist. We limit how many enuresis patients I see in a day. That's a form of autonomy. I want to get more surgical cases in, so we have a set number of enuresis patients on my schedule every day. We control those aspects of the job that I can have control over. I can't always control OR turnover. I can't always control who my circulating nurse or my scrub tech is, but I can control my attitude. I can control how many cases I book in the day. I can control what order those cases are scheduled in. And when you're going into practice, you can negotiate what you feel like you need. We talk a lot about work-life balance, and I think Dr. McDonald did a lovely job of talking about having children. I have 3, just full disclosure. Um, but I think when we think about work-life balance, it's not so much a scale. It's not like if we're doing well at work, we're doing poorly at home, right? That's what balance is. It's about integrating. It's about figuring out ways to incorporate being a parent into your everyday life so that it's not always a conflict with what we do at work. And I'll give a silly example. My middle child is a freshman in college, and she spent her first semester in Rome, and there was a big time difference, and she was very homesick. So every morning I would get in my car, and with the time difference, it was the perfect time to talk to her on the phone. And then every day at lunchtime, I would check in with her. Again, it would be around dinner time for her. And that way I was integrating my parenting into my work schedule. So Phil talked about purpose, and I would say that we need to start by understanding what our priorities are. And trust me, your priorities are going to change as your life changes. My youngest child is turning 17 soon. I am staring down the barrel of being an empty nester. My life is much different than it was when I had a 2-year-old, a 4-year-old, and a 6-year-old, and I was a brand new faculty member and the only woman on faculty at my institution, right? My priorities are totally different now. And your priorities, which you should write down at least every 6 months, should reflect your values. What are your career values? What are your social values, including your family? What are your spiritual, intellectual values? What's important to you physically? I just ran my 10th and final marathon. That was important to me. And it was a great thing to do, and I'm glad I'm not going to do another one. What are your emotional priorities, right? We think about these things, and then we figure out how to incorporate that into our everyday lives, not the other way around. So I love this quote. The key is not to prioritize what's on your schedule, but to schedule your priorities first. And so if that means scheduling a little time during your lunch break to talk to your college-age child who's homesick, you should do that, right? If exercising is a priority to you, put that on your schedule first. See if you can start your clinic half an hour late, right? Today, my colleague had an extra OR day, and he started the OR at 9 because Tuesday mornings he takes his children to school. That's fantastic. I love the way he does that. Schedule your priorities first, and then the rest will fall into place. I'm a big fan of coaching, and Phil is a fabulous coach, so I will give him props there. And there are different kinds of coaching. So one of the things, I work in a practice with 3 pediatric urologists. We love to scrub with each other, and we coach each other in the operating room, teach each other new techniques, different ways of doing things. You can have career coaching, you can have life coaching. You look for not just mentors who give you advice, but sponsors who give you opportunities. Look for leadership roles that excite you or research opportunities that are interesting to you. And Phil talked about mindfulness. I love the idea of mindfulness, not just mindfulness meditation, which is what most people think about, but mindfulness meaning paying attention to what you're doing throughout the day, being present for your family when you're done at work. Another thing that Dr. McDonald talked about is the dual careers of being a parent and a surgeon. Is you come home and you need to be present for your children, right? And that's what living mindfully is all about. Then what about this growth mindset? So I think we a lot of times get stuck, and I found this myself, where I don't like to try new things that I know I'm not going to be good at. That's a fixed mindset. The growth mindset starts with the idea, I'm not good at suturing yet, but with practice, I can be. I'm not really good at writing papers yet, but I know if I practice, I'll become a better writer. And by thinking in this way of I'm not yet there, but I'm going to work towards that goal, I think that's when we really have the opportunity to become great in what we do every day. So purpose. And I loved how Phil talked about purpose earlier. It's that intersection between the things we're passionate about, the things that we're good at, and then our own history, right? It's that intersection there. And so I've done a lot of work on burnout, and that came from a place of feeling pretty hopeless about my career early on, and then discovering this topic and realizing that I could make a difference, right? So that became my purpose. And it was that intersection of those things. So I know it's getting late. So I'm going to talk about just at the end to practice gratitude. I'm a big fan of gratitude journaling, taking 1 minute at the beginning and the end of the day to write about something that you're thankful for, to make sure that the people who work with you know that you appreciate them. At the end of every OR day, whether it was good or bad or indifferent, I thank every person who worked in my operating room. It's a habit for me, and I recommend doing it. Let people know when they make a difference. Pay it forward. You know, I had a rough go in the beginning of my career. My residency was tough. It was a different time, a different place. And one thing I swore is that I would never have my residents feel the way I sometimes felt as a resident. That's paying it forward. Or I won our department's fantasy football league, $240. And I used it to take our residents out to a local brewery for trivia night, right? And so that's paying it forward. And then find what work is meaningful to you, whether it's your career work, your volunteer work, your family life. Do things that have meaning for you. And that is where you will be engaged in your life, not just in your work, but your home life also. Here are a few resources that I recommend that have been really helpful to me from a business point of view, the Thriving Urology Practice. For women, there are a couple of great Facebook groups. There are great podcasts that I really love, including Phil's podcast. I'll put in a plug for there. Just a couple of resources that I found helpful in my career. To finish up, the opposite of burnout is engagement. You increase autonomy by taking control of your own journey. You work on mastery by living your life mindfully and cultivating a growth mindset. Seek out meaningful relationships and understand your purpose by aligning your abilities with your passions. And above all, practice gratitude. Thank you so much, and good luck to all of you.
Thank you so much, Dr. North. And as we kind of bring the rest of our team members to the room, I did want to ask you, how do you schedule in priorities? I think our learners may have a little bit harder time while they're in training. So do you have any tips for them related to what they can do that's within their control?
Absolutely. So I think there are a couple things. One is one nice thing about having work hour regulations that most programs, not 100%, but most programs follow. So our residents get post-call days, and using that opportunity, first of all, to take care of yourself, first and foremost. And second of all, using that as an opportunity to connect with the people who are important in your life. Make doctor's appointments, make therapy appointments, make coaching appointments, but to use that time to do the things that matter to you most. And it's very easy to give up that time to doom scroll on Facebook, right? To get lost in all of the, news or whatever. It's really easy to lose that time by not planning it ahead of time. Sleep first and foremost. I'm a big believer in sleep. Like I said, I'm usually heading to bed around now most nights. And I don't have little kids at home anymore, so I can't use them as my excuse. But then to do things that are really going to give you value for that time, right? And sometimes, on weeknights, you want to schedule dinners and stuff, and you don't know when you're going to get home because you have no control over the OR. I get that, but everybody gets an occasional weekend off, right? We get days off. Like, really figure out what would be the most meaningful way to use that time. Not the easiest, but the most meaningful. And most people have their schedules about a month out, right? So there is time to connect with that person who really brings value to your life, right? And that's what I would recommend. I think we all waste an awful lot of time. I'm guilty too. I'm not putting myself above that. I've been known to doom scroll on Facebook or get stuck on, whatever game is on my phone. I'm as bad as anyone. But I think, if we really want to have value and meaning in our very busy lives, that's the way you do it.
I think that's awesome advice. Scheduling it in, or else it just kind of disappears. So we have a couple questions from the audience in the last few minutes. And there was a question. So Dr. Parazio, what are some examples of the 20% a resident might have control over to stay mentally balanced?
Yeah. The hard part is you don't have control of when you got to start rounds necessarily and when the OR is going to start. But as soon as the day ends, you have control of your life. And so you can decide if you want to go for a 20-minute walk. You can decide if you want to try and eat healthy, or you can decide if you want to go to McDonald's and have a cocktail and sit on the couch and watch Netflix, all of which are valid choices. You just have to decide what's important for you on that day and towards your purposes and goals. So, and what I meant by the 20% too is don't get upset about the operating room. Don't get upset about having to write consult notes. Don't get upset about, the fact that you've got to hold the pager. Those are things that are out of your control because that's the system around you. So either focus on internal, or as you grow in your career, then you can focus on the 80% and make things better for other people.
Yes, I'm trying to do that.
We're all trying.
No, that's an awesome answer. Yeah, if you can't fix it, maybe don't dwell on it so much. I wish you had told me that when I was a medical student and you were my senior, resident. But learning now. And then we have another question for Dr. Gabrielson. Are there any exercises that you'd recommend for those that are using a lot of lead? So maybe our endourology crew. Is there any resource or something that you can give this audience to maybe help with that?
Yeah, so this is not necessarily specific to endourology or wearing lead aprons a lot, but the Mayo Clinic, if you type in Mayo Clinic and you look up Susan Hallbeck, she has an entire page. She has a lab. She's a human factors PhD, and her entire lab is devoted to stretching related to surgeons. And so she has these instructional videos, and I'll see if I can post it in the chat as a PDF, but they're very easy to follow, and you can actually do some of these stretches while you're scrubbed in or in between cases. And so they're step by step. I would highly recommend those. I actually have encouraged some of our folks to do it in between while we're waiting for a suture or something like that.
That's great advice. You can do these exercises even while you're waiting for suture. Okay. And one last question for the audience, for all of our team here. Coaching. We hear a lot about coaching. I think that's something that evolved after I was in training. I know we have a couple coaches on the call. What is everyone's perspective, and what if you don't have limitless funds to have 5 different life coaches? What can you do about that? Maybe I'll start with Dr. North and then ask Dr. Parazio to finish up.
Yeah, so right. I mean, coaching is definitely like a thing. My department right now is paying for all of our residents to get coaching, which I think is fantastic. And I've worked with Phil very briefly. I think coaching can be great, but I think we can coach each other, right? I think that you don't have to pay thousands and thousands of dollars for someone really famous to get benefit out of using a coach. I think, for my team, for the 3 of us, I try to coach my other faculty members informally more than formally. But I think we all have those trusted friends or trusted colleagues that we can run. I'm trying to figure out. I'll tell you something that happened to me recently. I had applied for a position in an organization outside of my hospital and found out that I didn't even make it to the interview stage. And I had been told I was like a shoo-in for this position. And so the way I handled it is I reached out to a couple of people that I've worked with through AUA stuff. And I was like, I really thought I was going to get this position and I'm not going to get it. I don't know what I'm going to do next in my career in terms of, and it was great. I had a 30-minute conversation with a friend and colleague from another institution who ran through, it was really, really helpful. And it helped me change my mindset about it. So I didn't pay him anything. I sent him a text message and said, I'm feeling kind of down about this. Do you have any advice for me? And, 30 minutes later, I had a whole new perspective on my career. So I don't think coaching has to be something you pay for.
Yeah, I agree with you, Amanda. And I think we're going to see more coaching training in residency and faculty training. And the basic premise of coaching is that you're helping someone achieve what's within them already. And it's different from mentoring. And the way I think about it is, with mentoring, let's just use grant writing for an example. There's an instruction manual for how to write a grant. And if you're a mentor, you show somebody how to use that instruction manual. What you're doing as a coach is you're helping somebody write their own instruction manual, how to solve that problem and solve future problems. And it's a skill set just like any other. It's really about being a good listener. It's about reflecting back what people are putting out there and helping them find the right answers. So you're right. You don't need to pay a lot of money for this. It's a relatively simple skill set, to be honest with you, but you do need training if you want to do it. And there's lots of ways to seek that out. And I think we're going to have more funding and more interest in this as we move forward in our careers.
Awesome. Well, I just want to thank all of the panelists here spending their evening with us to help promote wellness of our learners. Just another plug, make sure to sign up for as a medical student for free for the AUA. Join us in Las Vegas. It's going to be a lot of fun. We're going to have a great medical student education forum. You're going to get to see a lot of the people on this call right now present their awesome research, and we'd love to meet you. We also have some, we're going to post this so you can distribute it if you find it worthwhile. And then a couple people have given you contact information if you have an interest. We all love to do research. Well, we wish you the best, and we hope you have a great night. And thank you again to our panelists and to the AUA for supporting us.